Hi, my name is Farzaneh Firuznia, and I'm going to present a clinical case on chronic obstructive pulmonary disease or COPD. Chronic obstructive pulmonary disease or COPD is an inflammatory lung disease characterized by chronic, persistent airflow limitations that is not fully reversible and interfere with the quality of life. Symptoms include shortness of breath, cough, mucus production, and wheezing. COPD is one of the leading causes of death and disability worldwide. COPD is the fourth leading cause of death in the US. Around 16 million Americans are suffering from COPD. The prevalence of COPD is higher in women. Etiologies include environmental factors such as pollution, noxious fumes, or particles such as tobacco smoke. Asthma. The combination of asthma and smoking increases the risk of COPD. Genetics. Respiratory infections at an early age and low birth weight. 1% of COPD cases are due to alpha-1 antitrypsin deficiency. The pathologic changes of COPD occur in large central airways, small peripheral airways, and the lung parenchyma. COPD includes emphysema and chronic bronchitis. In emphysema, the destruction of alveoli through the breakdown of elastin makes alveoli abnormally inflated, damaging their walls and making them harder to breathe. In chronic bronchitis, bronchial inflammation causes bronchial edema, increased size, increased number of mucus glands and goblet cells in the airway epithelium, increased smooth muscle hypertrophy with fibrosis, and narration of airways. Chief complaint, history and physical exam. The patient is a 72-year-old Caucasian male who has experienced frequent coughing, excess sputum, shortness of breath, and fatigue for a couple of years. His symptoms have gotten worse since yesterday. I go straight to the positive findings in review of systems, which are frequent coughing, wheezing, excess sputum, shortness of breath, fatigue, stage 1 hypertension, and allergy to dust and pollen. In addition, he smokes 1 to 4 cigarettes per day. He also has a history of COPD for a couple of years. Assessment: frequent coughing, excess sputum, shortness of breath, fatigue, stage 1 hypertension, COPD, and allergy to dust and pollen. He smokes 1 to 4 cigarettes per day. The patient also has paradoxical abdominal movement, increased expiratory time, and uses accessory respiratory muscles. In auscultation, the breathing sounds diminished and wheezing was heard. Blood pressure is 138/85, heart rate is 85, BMI 26, O2 saturation is 89%, and FEV1 is 45%. Differential diagnosis. My primary diagnosis is COPD exacerbation, but the other diagnoses are heart failure and lung cancer. Recommended diagnostic testing: COPD assessment tool, spirometry, the ratio of FEV1 and FVC, which less than 70% shows COPD, chest X-ray to identify potential comorbidities or rule out other etiologies such as heart failure, exercise testing, assess the level of physical activity, CBC, to check for anemia, BNP if suspicious for heart failure, ECG, exclude cardiac disease, pulse oximetry, if less than 92%, check the ABG, alpha-1 antitrypsin deficiency, screening in patients younger than 45 whose spirometry results demonstrate COPD and have minimal or no smoking history or a family history of COPD. The gold standard for diagnosis of COPD is post-bronchodilator spirometry. Classification of COPD severity. In my patient, the FEV1 is 45, which means he has severe COPD. The red curve on the graph demonstrates my patient's FEV1. Treatment plan for COPD exacerbation. The first one, we start with bronchodilators. Short-acting beta agonist or SABAs with or without short-acting muscarinic antagonists or SAMAs are recommended. The next one is long-acting beta agonist or LABA and inhaled corticosteroids or ICS combination. Systemic steroids are used to improve lung function and decrease recovery time in a COPD exacerbation. Prednisone 40 mg for 5 days is recommended. Antibiotic therapy for an exacerbation is controversial, but initial empirical treatment is usually with amoxicillin, clavulanic acid, a macrolide, or a tetracycline. Oxygen therapy for patients with O2 saturation less than 88%. Follow-up after 2 week to 1 month intervals. Patient family education. The most important factor to reverse the COPD exacerbation is to quit smoking. Control his breathing. Talk to a respiratory therapist about techniques for breathing more efficiently throughout the day. Clear his airways, exercise regularly, eat healthy foods, avoid air pollution. He must visit his doctor regularly, get an annual flu vaccination and regular vaccination against pneumococcal pneumonia to reduce the risk of infections. Coping and support. Living with COPD can be challenging, especially as it becomes harder to catch his breath. As a result, he may have to give up some activities he previously enjoyed. Clinical practice guidelines used. My preceptor follows the same guidelines, but he prefers to visit his patient 1 week after COPD exacerbation. He believes it reduces the hospitalization. And these are my references. Thank you for watching my presentation.